Welcome, everyone, and thanks for joining us tonight. My name is Jane Ransom, and I'm the Executive Director of the American Brain Foundation. And tonight we're going to learn about diversity, equity, and inclusion in autism research. The American Brain Foundation is committed to sharing valuable resources and increasing public awareness of brain disease. So webinar events like this one tonight are opportunities to connect you with experts in various topics of interest around brain disease. The foundation funds research across the entire spectrum of brain diseases because we know that the diseases are interconnected. Curing one brain disease means being able to cure many brain diseases. So let's move on to our topic of conversation for tonight: diversity, equity, and inclusion in autism. I'm just delighted to welcome our guest speaker, Dr. Audrey Brumback. Dr. Brumback is a pediatric neurologist at Dell Children's in Austin, Texas. She specializes in the care for children and young adults with neurodevelopmental conditions such as autism. And as a physician researcher, Dr. Brumback leads a team of researchers to understand how changes in the brain's electrical activity can cause behavioral health symptoms and affect quality of life. Dr. Brumback is an assistant professor at the Dell Medical School at the University of Texas at Austin. She and her team studied the interface of neurology, psychiatry, developmental behavioral pediatrics, and basic neurosciences. Dr. Brumback is a prolific writer of peer-reviewed papers and a nationally recognized researcher in the clinical assessment and management of autism spectrum disorders and related developmental pediatric conditions. In 2022, she was awarded a seed grant funded by the American Brain Foundation to advance diversity, equity, and inclusion in autism research. Despite consensus that the early identification and treatment is beneficial to people with autism spectrum disorder, Latino children are consistently diagnosed at older ages than their white peers. One barrier to early diagnosis is the lack of language-appropriate and culturally relevant diagnostic tools. In her research, Dr. Brumback tested the efficacy of a new tool, which was developed in Latin America for use in the United States. Welcome, Dr. Brumback.
Thank you so much, Jane. I'm so delighted to be here. So I will share my screen so we can see my slides. Thank you so much. I'm super excited to be here. And so the agenda for tonight, I'm going to give a brief talk followed by a Q&A. And so in the talk, I'll discuss autism diagnosis. How do we diagnose it? What are the criteria by which we diagnose it? What does that actually look like for families going through the diagnostic odyssey? Why do we want to diagnose it early? And who has access to that diagnosis? And as Jane alluded to in the introduction, that's not something that has been equitable. And then I'll tell you about our ABF-funded research and our future directions. And then we'll have a lot of good time to chat, and I can answer all of your burning questions. Okay, so what is autism? Well, it's defined by behavior. And the things that we look for are atypical social communication, focused interests and repetitive behaviors, and sensory differences. And these are things that start early in life, and they're not better explained by the person's intellectual capabilities. So I'm just going to pause here and put in a plug for neurodiversity. So the conversation in the autism field has recently been to really try to understand, how do we define a disability? And historically, the disabilities have been defined by the people who don't have those disabilities. And so it's no different for autism. we as a profession have defined autism in terms of as a disorder, deficits. There's a lot of conversation now about how maybe it's not all bad. And I'm a big believer in that. And so I think that one sort of piece to come away with is, from speaking from somebody who is not autistic, what I find is that we don't understand them and they don't understand us. But when we are interacting among our same brain type, we're just fine. So for instance, take this boy who, classically, as diagnosticians, we would say, well, this child's inappropriately playing with toys. He's lining them up. He's not using them as cars. He's organizing them. Well, for that kid, from his perspective, he's just playing with toys in a way that doesn't make sense to you, but it makes sense to him. Another example would be, a child who is, having a meltdown because they're being handed a cup that's not the color that they were expecting it was going to be. And so by our clinical criteria, we say that this is evidence that this person has difficulty dealing with changes in routine. Well, from that person's perspective, they just want the world to make sense. They were expecting a green cup, now you're handing them a red cup. And so I use this as a way to just introduce this idea of neurodiversity and how this is sort of we are just in our infancy of this conversation. There are many people who have autism who have profound challenges. And the majority of the work that I do as a neurologist is centered around helping people who come into my office who are requesting help. And so that's sort of the point of view that I'm coming at this conversation from. And just with the understanding that there are lots of different ways that people are approaching this conversation, and they're all valid. So how do we actually make this diagnosis? So the DSM-5 is the book of psychiatric diagnoses that outlines, based on clinical observation, caregiver report, and interview, a series of symptoms. And if you have those symptoms and the clinician doesn't think that they're due to something else, and they started early in life, then you will gain a diagnosis of autism. So this doesn't have to be done through standardized assessments. So for instance, in my clinic, I don't use standardized assessments. I have an interview that I do with the family and I observe the child. And it's sort of been, it's my own, just like every clinician's clinical, interactions with their patients is, it has my own take on sort of how to ask these questions in a way that feels most comfortable to me. But, this is what I do all the time. And so for me, it's pretty easy to ad lib. For people who aren't doing diagnostic assessments all the time, for people who, aren't thinking about autism all the time like I am, it really helps to have an interview that's written out for you that you can, read off the questions in the right order. You can make your observations and rank them rate them according to a scale, and then have, a calculated score at the end of that helps you complement your clinical suspicions. And so that's what we're going to talk a lot about today, are these standardized assessments and how the ways that we use them have been disadvantaging kids who do not speak English natively. So I'm going to go through real quick and talk about autism symptoms. I think this is really important to go through and talk about the range of autism symptoms. So I will go through each of these symptom categories, and I'll talk about what the stereotypical presentation is, and then I'll talk about kind of what the more subtle presentation is, and this is typically in females. I'm not going to talk about female autism today specifically, but in general, females are underdiagnosed with autism. And part of it is because their presentation is not stereotypical. So starting with social emotional reciprocity. Stereotypically, we think of a person who lacks empathy, they're disengaged from other people. In a subtle presentation, this can be somebody who is hard to engage in small talk. It's hard for them to share their feelings. They can talk about stuff, but they can't really talk about, how they're feeling about things. For these people, it can be easier when there's an activity to sort of grease the wheels, like board games. This is why my brother plays a lot of Dungeons and Dragons. It's because it takes away the pressure of having to maintain a back and forth conversation, but you still get the benefit of being around other people. In terms of nonverbal communication, we think of a person who doesn't make eye contact. They have a flat affect. They don't point at things to share experiences or to get what they need. On the more subtle end of the spectrum, this can be somebody who just has discomfort with eye contact. They know they're supposed to do it, and so they do it, but it's something they have to work at. This can be somebody who maybe has a full range of facial expressions that they have to work at making on purpose. It doesn't come naturally. And this might be a person who doesn't quite understand other people's facial expressions, doesn't understand when they're using sarcasm. This could be somebody who doesn't think that there's a difference between teasing and joking or being bullied. They might think that any little, gentle ribbing is a bullying, or they might receive bullying from somebody and think that, oh, this person's my friend. This could be somebody who has unusual prosody, so a more robotic voice, or somebody who has difficulty in modulating the volume of their voice and talks really loud, sort of regardless of the situation. And then this can be in little kids. These are kids who can point, but to only have their needs met. They're not pointing to, show mom the plane in the sky. They're pointing to get the thing that they want out of the pantry. In terms of developing and maintaining peer relationships, we stereotypically think of somebody who doesn't have friends and doesn't want friends. In reality, this can be somebody who gravitates towards older or younger kids rather than peers. They can be somebody who, when they are with peers, they prefer to play a defined role. They take on the teacher role or the helper role. This can be somebody who's described as bossy. When they're playing, it's their way or the highway. And then for people who have friend groups, one thing we find is that friend group is often people who are more like family, people who've known this person, since they were little and accept the person for who they are as family does. Okay, let's talk about our second category, starting with repetitive interests and restricted behaviors. Starting with stereotypies. So we stereotypically think of echolalia, somebody repeating back verbatim what they've heard, somebody who's rocking their body, spinning in place, flapping their hands, lining up objects. On the more subtle side, this can be somebody who I asked, does this person have an eye for detail? Are they highly organized? Do they enjoy watching the same movie over and over and over again, reading the same book over and over and over again? And the motor stereotypies can be something as simple as picking at cuticles. In terms of cognitive inflexibility, we stereotypically think of somebody who has rigid routines, an intolerance to change, maybe some odd rituals. On the more subtle side of things, this can be somebody who is a true perfectionist and gets really easily frustrated when things aren't as they need to be. This person can transition from one thing to another, but it might be very anxiety provoking for them. They might hide it, but their internal experience is one of anxiety. And this is when it comes to how teachers perceive their students. Many of these kids are strict rule followers, and so their teachers love them because they do everything they are supposed to do during the school day. Okay, last slide on this topic. We'll talk about interests and then about sensory. So stereotypically, we think of somebody who has interest in sort of odd topics like memorizing train schedules. In a more subtle presentation, this can be an intense interest, but it's sort of in normal, quote unquote, topics. So, I often hear like, well, aren't all girls into horses? Yes, many girls are into horses, but it's really about the intensity of that interest. That if you ask about it specifically, you find that, wow, this person's like really into horses. And I ask that way sometimes when I talk to families. I'm like, is there anything they're like really into? And parents know what I'm talking about if their child does have an intense interest. Finally, on the sensory front, stereotypically, we think of somebody who's watching fans spin, who's spinning the wheels on their toy car, somebody who doesn't like to be touched, the tags in their shirts bother them. On a more subtle presentation, this can be somebody who has a high pain threshold. They are running, they skin their knee, and they just get right back up and keep running. It can be somebody who perceives temperature in an odd way. So somebody who in Chicago is wearing shorts year round, or in Texas is wearing, sweatpants year round. This can be somebody who really enjoys visually aligning objects, or looking at things closely or out of the corner of their eye. And they might know that looks odd to others. And so they might do it only when they know nobody else is around. Picky eating is very common. And then in terms of seeking out sensations, that sensory seeking phenotype, I will ask families, does your child seem to explore the world through their fingertips? So somebody who really enjoys rubbing surfaces. Okay, so we've just gone through the diagnostic criteria for autism spectrum disorder, and we've discussed how we can have stereotypical presentations or more subtle presentations, and that tend to be more prevalent in females. Okay. Next, we're going to talk about why do we want to diagnose autism early? This has been, a real, something that we have been stressing as a community is, we have to identify it early. Well, why does it matter? Well, I'll highlight two things. So first is it really reframes how we interpret somebody's behaviors. So if you have somebody who's melting down for seemingly minor things, or, can't tolerate, being in the restaurant, somebody who just seems to kind of have an odd intonation to their voice, or doesn't quite, you're not quite on the same wavelength as them. If you know that person's autistic, it just reframes everything as like, oh, okay, that makes sense. And so this is particularly important for kids when the extended family thinks that this is all because mom is spoiling the child, mom is, indulging the child, and just needs to be, more firm with the child. That would fix the child's behavior. And so parents often feel really alleviated when they can go to their extended family and say, look, this is why he's acting differently or she's acting differently than we expect. It's not that the mom is causing problems. It's that I'm trying to work with somebody who has a different brain type. And then to understand how we can help. So, by identifying how somebody processes information, what their likes and dislikes are, and, how what are the things that they find challenging, what are the things that they are naturally good at, we can bring that together to create a plan to help the person thrive. So tonight's talk is about diversity, equity, and inclusion in autism. And so I'll just say plainly that autism is underdiagnosed in people who are not white. So compared to white kids, Black kids are much more likely to receive other diagnoses. And historically, Latino kids have been 50% less likely to be diagnosed with autism spectrum disorder compared to their white peers. So let's talk about why that might be and sort of all the steps along the way to getting a diagnosis and then treatment, and talk about sort of where might the barriers be that could be creating that situation. So the first step is the individual themselves, typically a teenager who's been reading online, or a family member or the primary care clinician raise concerns and ask for an evaluation. Then they get referred typically to a pediatric neurologist, a psychologist, or a developmental behavioral pediatrician. At this stage, we do our diagnostic evaluation and we provide diagnoses. Then the person can access therapies like ABA, which is applied behavioral analysis, and we can talk about that in the Q&A if people are interested. Speech therapy, occupational therapy, those aren't autism specific, so people can typically access those regardless of whether they have an autism diagnosis. But for special education, there is a specific classification for autism, and so it is helpful for kids to access different special education services if they carry a diagnosis of autism. Okay, so what are the barriers that families face? And I'm going to particularly focus on Latino families here, since that's what our ABF funded research is on. So there are many barriers. I'm going to focus for the purposes of our research on differences in language and differences in cultural expectations. So I will give one example to highlight one of the ways that both language and cultural expectations can lead to a decrease in either of any of these three steps, basically not having the child present to care for a diagnostic evaluation and maybe not be referred for therapies the way they would otherwise. So let's talk about language. So first, many Latino families, the parents are Spanish speaking only, where the children are bilingual. And so what we found is that parents who are Spanish speaking only and who have bilingual children are not picking up on, they're not reporting that their kids have language delays or other delays in communication the way that that families do when the child and the parent are completely congruent in their language. And so, that right off the bat, that you don't have the family bringing the kid in and asking for a referral. Next, cultural expectations. So, in terms of, say, eye contact. So in many cultures, including many Latino cultures, making direct eye contact is considered impolite. And so the fact that a child is not making good eye contact isn't necessarily picked up on because it is not as striking a difference between them and the typically developing kids. So I'll go through a couple of slides of data to demonstrate sort of how this looks in terms of the differences in prevalence of who has a diagnosis between Latinos and whites. So here, I just want you to focus on the colored bars without reading too much. On the bottom, each of these pairs of bars is for a different year, so marching forward in time from 2002 through 2018. The rate at which autism is recognized in white kids is in blue. The rate at which it's recognized in Latino kids is in orange. What we see is that year over year, there's a drastic difference in the prevalence rate of autism. And so, but then we look at 2018 and gosh, that looks pretty good. Actually, the orange bar is taller than the blue bar. Interestingly, this was the year that California was added to the surveillance network. And I won't show you these data today, but California has historically been, has more parity in terms of the rates of prevalence. And so many of us believe that this sort of catching up in this prevalence rate is due to different samples being taken over, different samples year over year. Okay, so what can we do? So if we take just that language barrier where we have, a primarily English-speaking clinician and we have a Spanish-speaking family, well, gosh, maybe if we take one of those standardized interviews and we just translate it into Spanish, that'll help. So if we take the gold standard English language diagnostic interview, which is primarily used for research purposes, but it's sort of many of our clinical interviews are kind of modeled off of ADIR. It's got great sensitivity, great specificity. Well, if you translate that directly into Spanish, we do not have good sensitivity. We do not have good specificity. We're not really able to distinguish kids who have global developmental delay from kids who are autistic. So what do we do about this? Translation alone isn't enough. So fortunately, Doctora Albores Gallo in Mexico got together a team to create a new diagnostic tool for Latino families. So it's called CRIDI, which stands for the Criteria Diagnostic Interview. And basically, this team of professionals took the best parts of all of our English language assessments, all of our interviews and rating scales, translated it into Spanish, but also redesigned it so that it was reflecting cultural differences. They wrote it using colloquial language, and the examples that we will give to families to get them to know what we're talking about are culturally relevant to Latino families. And so what they found is that this actually works really well to diagnose kids. This was in Mexico and Central and South America. And so we thought, well, translation alone doesn't work. Now we've got a new tool in Spanish. Well, let's see if that tool that was developed in Central and South America, Mexico, Central and South America, can be useful for diagnosing Latino families in the US. So the basic idea of our study is that Ligiola Aranaga Sanchez and our excellent undergraduate assistant, Evelyn Guevara, they see the patient for a first visit, and they do this CRIDI. It's like an hour-long diagnostic interview. It has all the rating scales. And at the end of that, they provide, what their diagnostic impression is and what this diagnostic tool has to say. So then the family comes back and they get routine clinical care with me. So I do my standard autism new patient evaluation. And then they also get testing through Santa Venegas with developmental testing and an ADOS, which is one of these standardized assessment tools where you observe the child's behavior in a standardized way. And so we are testing three things. One is discriminant validity. So how well does this allow us to distinguish between kids who have developmental delay versus autism, versus both? We're going to test its sensitivity and specificity. And then we're going to understand, based on each of the items in this tool, in this interview and rating scale, which of the items are actually useful, because maybe we could pare it down even further and have it be an even more brief assessment, but still have the benefit. So once we complete our pilot study, the plan is to expand nationally. So we are currently in Austin, Texas. We're enrolling about 50 kids. Once we have these pilot data, then the plan is to apply for an NIH grant where we can test this diagnostic tool in other populations with other clinicians in other institutions. So I think that I'll end by saying that these pilot grants that ABF offers are really transformational. So I have been wanting to work with this group of people for a long time. And we've talked about it, and having this ABF funded project has actually catalyzed our collaboration. And so now we are collaborating legitimately. We're not just saying we want to work together. And so it was really made possible because of these pilot grants that ABF offers. Okay, so in review, tonight we've talked about autism diagnosis, how we go about doing that, why we do it, who has access to that diagnosis, and then the type of work that we're doing to try to alleviate those disparities. And so now we can have our question and answer. Thank you.
Wonderful. Thank you, Dr. Brumback. Why don't I get the ball rolling? I hope we'll ask the questions in the chat, and I hope other people will add questions to the chat or even just raise their hand, whatever works for you. I wanted to ask you, you showed us all those slides where you start with a stereotype and then the subtleties kind of go toward the female. And could you make a similar chart showing stereotype white and then subtleties toward Hispanic or Black children?
Yes. Yeah. So I think that's a very wise question. So I think that, I'm going to have to really think about that one in terms of for each of the diagnostic criteria, kind of what are the ways that it can present differently in different cultures. And I know that people have done a lot of, research on this. And so I think that, we are shaped by our environment. And so for kids, I think that the example of the eye contact is really sort of the most salient one, where, as a clinician, I am evaluating somebody who, in my culture, we lock onto each other's eyes all the time. And so if I see somebody who isn't doing that, I'm going to, first of all, assume that that's a disorder, and I might overdiagnose somebody. Whereas somebody who has behavior that's congruent to my culture, I'll be able to recognize that more easily.
Thank you. Phyllis Shepard has a question.
Yes, my question is, have you used or are you familiar with the use of stem cells for autism?
Thank you. So I am familiar with the use of stem cells for autism. And right now, as a clinician, I do not recommend using stem cells for autism. We do not have the research has not been done that has demonstrated that it's safe or that it's effective. And it's a big deal to have stem cells injected into your body, even if they're your own stem cells. And so the advice that I give generally to my patients is don't do it. If there's a clinical trial that you can participate in where it is, really closely monitored, and there are outside people who are monitoring for adverse events, in a tightly controlled setting, I'm okay with that. I think, that is how we're going to determine whether it is useful. I have a lot of families who are flying internationally to access these treatments. And I generally recommend against it.
There's a physician in Florida who had stem cells used on his son who is autistic with very good results.
So
amazing results.
Yeah. So Phyllis, you have just brought up, I think, one of the main areas of growth for our treatment of autism. So what anybody who has interacted with people with autism know how heterogeneous it is. So, I sort of make fun that my husband is left-handed and, it's been working out okay so far. But, we have different brain types. He's left-handed, I'm right-handed. That means that our brains are wired up in a different way. And there's lots of different reasons for having your hand, being right-handed or left-handed, just like there's lots of reasons to have autism. And so what I think we're going to find is that there are treatments that are really effective for certain people, but that when we say, okay, well, let's try that in everybody, it doesn't work. And we're not able to sort of see with our standard clinical trials the benefit because, for the one person it really worked for, there's a whole ocean of people that it didn't work for. And so
that's
in the
true
field,
of any treatment.
Let's take on another question. Somebody else says, what are the numerous ways that we as a society can integrate all brain disorder diagnoses with a commonplace vocabulary for both families, friends, coworkers, school teachers, daycare facility workers, and the general public at large? That's a question that the American Brain Foundation asks all the time. What are your thoughts, Dr. Brumback?
Yeah, what a thoughtful question. I think that the spirit of your question is what we are all working towards. And I think that trying to have that common language, at least for autism, comes through the revision of the DSM-5 or the DSM, which is currently in its 5th edition. I think that we will evolve more as we continue to have this conversation when we get into DSM-6 and 7. That's sort of the main way that we as medical professionals standardize the language we're using so that we can all be on the same page about what it is that we're diagnosing and treating.
Okay. Another question here is, where does personality characteristics end and the autism diagnosis begin? Many of the subtle issues you describe as autism reflect parts of my own personality. But no, I am a senior adult who definitely is not ASD. I just think we tend to put any personality difference into the ASD category and perhaps label a child incorrectly due to differences in personality characteristics.
So, yeah, I agree. This is a big issue. What do we call a disorder? Where do we draw that line? We're evolving in where we draw those lines. And I guess from my standpoint, the main answer to this is going to be to have an understanding of the biology where, we can do some measurements of brain activity, brain connectivity, and to be able to say like, oh, this person's brain is fundamentally different, and we have some objective measurements for that, as opposed to somebody whose brain is not fundamentally different, but is a little, different, but not fundamentally so. I think that's really going to be the answer for us to be able to understand it at a biological level.
Okay. We also have a question here. How do teachers help students who have a definite need, but families don't want a diagnosis?
So I think that understanding why the family doesn't want a diagnosis and understanding sort of the cultural factors that are playing into that is really helpful. And so I think that, one thing that, as a neurologist, I am always so excited when I get to talk to the teachers, participate in the process of creating special education plans, so we can have that conversation. Because we're coming at it from different points of view and knowing the family in different ways. So I think that would be my first question is, why do we think the family doesn't want to have a diagnosis? And then working on that first.
Do you expect that your the research you're doing now, as you come to understand what's the best way to test in the Latino community for autism, the results of that could extend to helping teachers learn to spot it, in a way, maybe a white Euro-American teacher who doesn't know the Latino culture as well.
Yeah. So our goal would be that this tool could be used by primary care doctors. This could be something that, you don't have to wait a year to come see the neurology specialist or the developmental pediatric specialist to have this. This could be something that the that the pediatricians or the family medicine doctors could do in their clinics. And so then it basically becomes something that can be a conversation between the medical team and the educational team even sooner. I think that as we sort of, I think that a lot of what can help teachers is us giving talks like this to help people, sort of see things the way I see things. And for me to listen to, educational experts give talks from their point of view, because we really are all coming at this from different angles.
Do you think, I keep thinking of the book, maybe some of you on the line have read it here, The Spirit Catches You and You Fall Down, about, a Hmong girl with epilepsy, and that her seizures and her condition they're valued differently in the Hmong community than they are, or at least at the time of that book, that was in the 80s, I think. But but whereas in the Eurocentric community, it's just bad to have seizures, period. Whereas in a Hmong community, it might mean you have something special and you're in touch with some things that the rest of us aren't. Do you feel like that there's that different kind of valuing in the world of autism by different cultures of some of these characteristics?
So I guess I'm going to answer that by kind of going back to your original question. You were asking about, would there be a spectrum that we could, from, one end of things to the other, where, not just females are on one side, but, people from different cultures or ethnic or ethnicities are. And I think that when I think about that question, I think that with male, female, we have clear differences in biology there. When it comes to people who have different ancestries, the differences, the similarities far outweigh the differences. And so, I just wanted to sort of get back to that point, which I think is really important of, that this is that a lot of this is cultural, and how things are perceived. And so your question here made me think of that. But no, absolutely. I think that, I will not pretend to be an expert on Latino culture. And so I think that that's a really interesting question. I think that's one that my collaborator, Sandy Magana or Sandra Venegas, could answer much better than I could. Yeah.
Thank you. Somebody else has said everyone has different ways of learned behavior and creating their own way of communicating with immediate family versus the general public outside the home. Is there a unified test that both teachers, daycare staffers, and government can collaborate on together?
Right. So I think this question sort of brings to mind the differences between an educational classification of autism and a medical diagnosis of autism. I think that your question sort of really speaks to this, because we're both the educators and the medical professionals are saying, we think this child is autistic, but we're using different criteria by which to judge that. And in the educational setting, the part of the judgment is this impacting the child's ability to access the curriculum of the school? And so often we'll have children who have medical diagnoses, but not educational diagnoses. It's pretty rare that we have the opposite. But I think that really speaks to the fact that, even, today when we have, the medical system and the educational system, we are still speaking different languages to a certain extent.
Okay. What is your vision for 5 or 10 years from now, where this research you're doing now takes you and your team and the whole country?
Well, my hope is that we can empower people, empower clinicians to feel confident in giving the diagnosis of autism. What I find is that people don't feel comfortable giving the diagnosis of autism. They really feel like they need to have, something else, an expert or, a scoring system that provides a supplement to their clinical suspicion. And so my hope is that we can take the process of diagnosing autism out of the clinic, the neurology clinic, out of the developmental behavioral pediatrics clinic, and have that be a primary care diagnosis. Primary care doctors diagnose other DSM-5 diagnoses all the time: depression, anxiety, ADHD. And so I feel that the diagnosis of autism should be no different. And so having this tool starting for Latino families, I think will help with that. But then, there's no reason we can't back translate this into English and make this widely available. And so my hope is that we can create a validated measure for both, that's culturally relevant for Latino families and for non-Latino families, for both Spanish speakers and non-Spanish speakers. So we're empowering primary care providers to be able to make the diagnosis.
Fantastic. Does anyone else have any questions? I think we've gone through our questions. Is there any final statement you'd like to make, Dr. Brumback? We've had you talking the whole time, so don't worry if you don't want to.
Yeah. I think that in general, I try to approach this entire topic with a lot of humility and a lot of acknowledgement that we are in our infancy of understanding brain conditions like autism. These are differences in the brain that really lie at the interface between psychiatry and neurology and developmental pediatrics. And I think that having these different specialties and expertise levels of, areas of expertise come together and have a common language, like we were talking about. I think that that's going to be what brings us into the next phase of our understanding of this disorder.
Okay, we got a couple more questions coming up here. One is, what is the demographic most affected by autism according to today's data?
So there's still a prevalence of males and of people who are white. The most recent data with the inclusion of California has now made it so that the Hispanic population is on par with the white population in terms of prevalence.
Okay, and another one is, could you mention the differences between autism and Asperger's?
Yeah, so Asperger's was an official diagnosis in the last version of the DSM. And I still use the term when I talk to families, because I think that it really, helps frame, for families, the conversation, because it is such a commonly used term. So Asperger type autism is really somebody who has normal language, normal intelligence, but they're autistic. And so, they're able to fully communicate, and they've had normal language development the whole time. That's really what Asperger's type autism is.
Okay. Can you talk about your experience with inherent or implicit racism when it comes to autism?
So, I think that the thing that I talk to my Black families about is making sure their kids are going to be safe in public when they are presumed to be older than they are, and they are seen as more threatening than they would be if they were white. And so I worry about the interactions between people with autism and police, especially in the Black community. And so it's definitely something I talk about, directly with my families. I don't want to sugarcoat it. I don't want to, use euphemisms.
Mhm.
I want us to be able to talk about it and have a plan so that when their child is dysregulated and encounters a police officer, what that looks like.
Can you talk about presuming competence when it comes to autism, especially with non-speaking autistic individuals? How do you diagnose and test non-speaking individuals and break through the communication barrier?
So I will answer that question in a little bit of an indirect way by talking about reading. So I am a big advocate for reading to kids. I think every kid should be a book lover. I think every family should be reading with their kids at dinner time and bringing their kids to the library, making them love books. A lot of my family, so I counsel all my families on reading, but a lot of my families who have kids who are autistic or hyperactive or both, they stop reading to their kids because they don't think that the kid's even listening. They're not showing sort of the standard signs that they're understanding, or the kid is flitting around the room and it doesn't appear that they're listening. But I say to that family, I say, if you say ice cream, the kid comes running. Like, they're listening, they're tuned into what's going on. They just might not be giving you the sort of typical signs that they are listening. So continue reading to them, even if it doesn't seem like they understand. So I think that this is a big challenge with navigating just interactions in general with people whose bodies are not working the way that that they would typically, whether they have a motor neuron disorder that's making them so they can't move their body, or somebody who has a brain disorder that's preventing them from having spoken language. And I think that, my answer is presume competence with everybody. We can gauge somebody's level of receptive language with their, whether they, when you call, okay, it's time for ice cream, if they come, I'm giving sort of a trivial example, but, we can gauge receptive language. And then for the expressive part, it's a matter of getting that person all of the speech therapy and the devices, the system and augmentative communication devices that are really going to help that person communicate.
All right, we're going to have two more questions, and then I think we're going to have to call it a night. The first one is, are Asperger's, cerebral palsy, and autism similar, and how do they differ?
So they are all brain conditions. Cerebral palsy is where there's a problem with the motor system, with your movements, and that is something that starts in the first year of life. And so it's separate from, you can have cerebral palsy and have normal intelligence, normal language, not be autistic, or you can have cerebral palsy and have these other issues as well. And so they're kind of separable in a neurologist's mind as different disorders. Whether Asperger type autism is different from a more profound presentation of autism, that is a whole topic for discussion that we don't have time for tonight.
All right. The last question is that the state of Rhode Island has implemented a driver's license with autism designation because many are high-functioning individuals who are able to work. Are other states doing this as well?
I don't know. I can't answer that because I didn't know it was happening in Rhode Island. So that's awesome. Yeah, I think that's great. I think that, we have, medical alert, bracelets for people with epilepsy, and, it gives somebody a quick, glance at, what it is that, this person is experiencing. And I think that having that kind of, ability to communicate quickly and succinctly when somebody's in crisis, what their baseline, way that they process information is and how they interact with other people. I think that's really, really important. And so I'm really glad to hear that Rhode Island is doing that. I think that's a great idea.
Okay. Well, we're going to close it down here, but I just want to thank you once again, Dr. Brumback, so much for joining us tonight. This, in about 10 days or so, this entire presentation will be posted on our website and on our YouTube channel. We'd love to see you again. We've got a great lineup of monthly webinars scheduled, including our next one on June 21st is called Controversies in Dementia Research with Dr. Ron Peterson. You don't want to miss that one. All those controversies are in the news right now. You can also follow us on social media to stay up to date on brain disease information and research. And you can also support innovative research to find the cures of tomorrow by making a donation. No donation is too small, and all are deeply appreciated. We can't do this without your support. So thank you very much, everyone, for joining us tonight. Have a nice evening. Bye.